Hello guys, welcome back to the session of rapid revision of anesthesia. This will be the most important session guys. In this video, we'll be covering the most important topics and the high topics that could be asked in your exam. Okay. So guys, starting with the session of anesthesia, we'll again go from the history, the PAC, the local anesthetics, the general anesthetics, the regional and the machines. Okay. Starting with the history of anesthesia. But before going for the history of anesthesia, guys, we'll just start with what is meant by the term anesthesia. What is meant by the term anesthesia? Anesthesia means what? And meaning no, aesthesia meaning sensation. Absence of sensation or no sensation or loss of sensation is called as anesthesia. Now guys, going back to the history of anesthesia, who was regarded as the father of modern anesthesia guys? W.T.G. Morton was regarded as father of modern anesthesia. W.T.G. Morton. Why he is regarded as the father of modern anesthesia? Why? Because Morton gave the public demonstration. You can see Morton holding this ether can. He gave the public demonstration of ether anesthesia in front of the whole audience. On what day he gave this demonstration? On 16th of October 1846. Hence, this day is also celebrated as World Anesthesia Day. 16th of October 1846 is celebrated as World Anesthesia Day. Who's the father of modern anesthesia? He is W.T.G. Morton. Okay. Then you also need to remember about father of spinal anesthesia. Father of spinal anesthesia is August Baer. August Baer. August Baer not only gave the first spinal anesthesia, August Baer is also a guy who introduced a technique called as IVRA. Later in the session, we'll come to know what is IVRA. Intravenous regional anesthesia. Okay. Hence, this IVRA is also called as Baer's block. It is also called as Baer's block. Okay. Next. In the history, the next point that we need to remember is the first clinical demonstration of nitrous was given by Horace Wales. Horace Wales. Horace Wales gave the first clinical demonstration of nitrous anesthesia for dental case. Okay. This was regarding the history of anesthesia. Now guys, the whole topic of anesthesia revolves around 5 techniques of anesthesia that we need to remember. What are the 5 types or 5 techniques of anesthesia? The 5 techniques. It doesn't mean that apart from that these are known. These are the common techniques guys. Okay? The 5 techniques of AX. AX when I am writing that means anesthesia. The first is local anesthesia. The second is spinal anesthesia. The third is epidural anesthesia. The fourth is nerve block. And the last technique is the general anesthesia. General anesthesia. The whole topic of anesthesia revolves around these 5 techniques. Okay. Now guys, local anesthesia, when it is said, when there is a small area made numb, local anesthesia. For root canal therapy, you go for local anesthesia. Spinal anesthesia is given for below umbilicus short duration surgeries. It is given for below umbilicus short duration surgery. Epidural anesthesia is given for below umbilicus long duration surgery. Okay, it is commonly given for below umbilicus long duration, but it doesn't mean that it is just confined for it. Epidural anesthesia can also be given for pain relieving technique, and it can also be given for above umbilicus surgeries, but majorly epidural anesthesia is given for below umbilicus long duration surgeries. Okay? Nerve blocks. Here you select a plexus of nerve and you give a local anesthetic into that nerve plexus. That is called as nerve block. Example of nerve block, it is brachial plexus block, it is femoral plexus block, and there are many plexus block. The last is general anesthesia. General anesthesia is basically very different from all these anesthesia techniques. Okay? How, sir? Why? Because in general anesthesia, the patient is made unconscious. The patient is made unconscious. Whereas in all these anesthesia techniques, the patient is conscious. Whether it is local, a small area made numb, whether it is spinal for below umbilicus short duration, you give spinal anesthesia. Epidural, below umbilicus long duration, you keep a catheter, and through that catheter you can give top-up doses. Again, the patient will be conscious. In nerve block also patient is conscious. The only anesthesia technique where the patient is unconscious is general anesthesia. Now, before posting the patient for the surgery, we take the patient or the patient comes to the anesthetist for a checkup to be done. What is that checkup called as? That checkup is called as PAC. What does PAC means, guys? PAC full form is pre-anesthetic checkup. Pre-anesthetic checkup. What is so much important about this pre-anesthetic checkup? When a person comes to my clinic for a PAC before surgery, I need to check whether he is fit to undergo anesthesia or not. But I will give my fitness based upon the 4 things that I do in PAC. What are the 4 things I look in the PAC? The first thing I look in the PAC is airway assessment. The second thing is hemoglobin. The third thing in PAC is the fasting. And the last thing is history of comorbidities. Again, these are the most important steps of PAC. Apart from that, we also look for other investigations, but these are the 4 important steps in PAC. In these 4 important steps, the most important step or the most important thing without which your PAC is totally a waste is what, guys? Airway, hemoglobin, fasting, history of comorbidities. Which is the most important? It is always the airway assessment. Very important, guys. Why? Because in the PAC, if you do a thorough airway assessment, then many of the anesthesia related deaths could be prevented. How, sir? How those anesthesia related deaths could be prevented? The most common cause of death during or the most common cause of death in anesthesia or during anesthesia is what? Failure to intubate, failure to secure the airway. In which patients will you fail to secure the airway? When you don't know whether your patient was having an easy airway or difficult airway, in those patients, airway securement is difficult. When you know that your patient is having an easy airway, you can easily intubate. But how will you know that your patient is having an easy airway or difficult airway? By doing airway assessment. Now guys, what do we do in the airway assessment? In the airway assessment, we tell the patient 2 things. Come on guys, we are discussing about PAC. The first step in the PAC is airway assessment. What 2 things we are telling to the patient? We are telling to the patient to open your mouth and lift your chin. As he is opening mouth, you again look for 2 parameters. These parameters are very important. The first thing is the Mallampati classification. Then the second parameter is inter-incisor distance. Okay? Mallampati classification is what, guys? If we zoom into this person's picture, you will come to know. As you are telling the patient to open his mouth, You can see some structures clearly. You can see the hard palate. You can see the soft palate. You can see the uvula. You can see the tip of uvula, the tonsillar pillars. Yani ke, the structures that you are easily able to see in the patient's mouth. If you are able to see all the structures, that means he is having an adequate space so that you can put the laryngoscope blade and lift the tongue for intubation. Is it clear? So remember, this visual classification of the structures is called as Mallampati classification. It's called as what classification, guys? Mallampati classification. Okay. So as you tell the patient to open mouth, you look for Mallampati and interincisor. What is interincisor distance? The distance between the upper and the lower incisor. That is called as interincisor distance. Second thing that you need to tell the patient is lift your chin, sir. As he is lifting his chin, again you need to look for two things. What two things we need to look when he is lifting his chin? You need to look for the distance between the mentum and the thyroid cartilage, which is called as thyromental distance. And you also need to look for the distance between the mentum and the sternal notch, which is called as sternomental distance. The normal thyromental distance is 6.5 centimeters, whereas the normal sternomental is double the thyromental, so it should be more than 12.5 centimeters. If the patient is having this much distance, that means his neck can be, he can be easily intubated. It's not a case of difficult airway. Right. So guys, we have discussed about the, you tell the patient to open mouth and lift his chin. While opening mouth, the most important thing that we need to look is for the Mallampati classification. So guys, now you can look at this classification. From Mallampati, there have been many questions being asked. Mallampati classification. So imagine a person comes to your clinic, he opens his mouth. As he is opening mouth, if you are able to see the hard palate, if you are able to see the soft palate, if you are able to see the uvula, if you are able to see the tip of uvula, and if you are able to see the tonsillar pillars, basically you are able to see all the structures clearly, that is class 1. That patient is Mallampati class 1. So just write there, guys. Mallampati class 1. Mallampati class 1 means hard palate, soft palate, uvula, tip of uvula, and tonsillar pillars visible. Tonsillar pillars visible. That is Mallampati class 1. As we were discussing Mallampati classes. Class 1 we have discussed. Now coming to Mallampati class 2. In Mallampati class 2, what structures do we see? Guys, this Mallampati classification is very important. The structures that you see in Mallampati class 2 is, you see the hard palate, soft palate, uvula, but the tip of uvula is not seen. Tonsillar pillars could be seen. Uvula is seen, but the tip of uvula is not seen over here. Right? So, Mallampati class 2 is hard palate, soft palate, uvula, tonsillar pillars visible. What is not visible, guys? Tip of uvula is not visible. That is class 2. Then there is Mallampati class 3. Class 3 means only hard palate and soft palate visible. Only hard palate and soft palate visible. Class 4 means only hard palate visible. Only hard palate visible. So guys, if only hard palate is visible or only hard and soft palate is visible, that means the patient is having a very low space to put a laryngoscope in the mouth. So this class 3 and class 4 are difficult airway. There is one more class, class 0. Class 0 means when this patient comes to the clinic, when he opens his mouth, you are able to see the hard palate, you are able to see the soft palate, you are able to see the uvula, you are able to see the tip of uvula, you are able to see the tonsillar pillars, plus you are able to see the tip of epiglottis. So basically, remember, class 0 is what? All class 1 structures. Plus, what is the main important thing? Tip of epiglottis visible. That is Mallampatti class 0. That is Mallampatti class 0. Okay. So that was regarding the Mallampatti classification. So once mouth opening you have checked. Remember, while you tell the patient to open mouth, you look for Mallampatti, and then second you look for interincisor distance. Interincisor distance. Normal interincisor distance is 4 to 5 centimeters. Okay? Some patients will be having low interincisor distance. In those patients who have low interincisor distance, how will you secure the airway? How will you put the endotracheal tube? Right? Can you put the endotracheal tube orally? No sir, not possible. We can't do laryngoscopy. So in patients who's having low interincisor distance, the best way to secure the airway is by tracheostomy. That is regarding what guys? Interincisor distance, right? Next. So next you tell the patient to lift his chin, and we have already discussed two distances that you discussed, thyromental and sternomental. We have already discussed. The normal thyromental distance is how much guys? It is more than 6.5 centimeters, and normal sternomental distance should be how much? More than 12.5 centimeters. Double the thyromental. Okay, so that's regarding the airway. Airway is very important. Apart from airway, you check the hemoglobin of the patient, which should be 10. Apart from hemoglobin, you check for the fasting. Regarding the fasting status, that's very important guys. Why do you tell the patient to be in a fasting state before anesthesia? Why? Because you want to prevent aspiration. You want to prevent the risk of aspiration. So fasting is very important, right? Fasting does not only play an important role for general anesthesia. Fasting is applied for all of the anesthesia techniques, whether it is local, spinal or any. Why? Because if at all the patient is undergoing any procedure under local or spinal or epidural, during the procedure, if there are some complications, we have to shift to general anesthesia, right? So how many hours of fasting is needed guys? In adults who is on solid food, how many hours of fasting is needed? 8 hours. Whereas semi-solid food, how many hours? 6 hours. Whereas if he is on liquid like water, then 2 hours of fasting is mandatory. Remember, this 2 hours is for liquids, whether it is adult or a child, right? In case of children, what we do is, in case of children, the protocol that we follow over here is, if the child is on water, we keep him fasting for 2 hours. Okay? If the child is on mother's milk, then 4 hours of fasting is needed. Or if the child is on formula feed, then 6 hours of fasting is needed. That is regarding the fasting status. The last thing in the pre-anesthetic checkup, before giving a certificate that the patient is fit to undergo anesthesia, The last thing that you do in the PSC is what, guys? You ask about the history of comorbidities. Now, guys, in the history of comorbidities, what are you asking? You are asking about the diseases the patient is suffering with. And based on the diseases, you will advise them, right? Remember, guys, the disease is not a problem for you. It is always the medicine that the patient is taking, because some of the medications can be continued before surgery, some needs to be stopped. So, guys, what are the medications that can be safely given and what are the medications that should be stopped before surgery? Remember, most of the A's can be given. Most of the medications starting with the letter alphabet A can be given. Whereas, what are the medications that we need to be stopped before surgery? There are a few medications, guys. There is a list of medications. But to remember guys, the medicines that are stopped before surgery, for that you need to remember what? You need to remember a mnemonic. Remember, guys, if there is a, MLC is Member of Legislative Council. Imagine there is a MLC woman whose father is posted for some surgery. That woman is very anxious about the surgery of the father. She'll be asking, will you allow me into the operation theatre and all? You will tell what? No, madam, you need to stop. Okay? Don't come in the operation theatre. We can't concentrate properly. Why? Because you will be constantly nagging. You will be having doubts in the operation theatre and all. So basically, remember, she is a hot MLC woman. Okay? Hot MLC woman. Why? Because just look over here. The drugs that need to be stopped before surgery are usually phrased in a mnemonic called as a hot MLC woman that need to be stopped before surgery. Okay, we'll discuss what is a hot MLC woman. Okay. Now, guys, what are the A's that can be continued? Aspirin in a dose of 75 milligrams can be continued, except if it is a neural surgery or any retinal surgery, then you have to stop aspirin. Okay. Next, anti-anginal drugs. Anti-anginal drugs can be continued before surgery. There is no problem with it. Okay. Nitroglycerin can be continued. Apart from that, anti-epileptic medications can be continued. Apart from that, anti-thyroid or euthyroid medications can be continued before surgery. There is no problem with that. Okay? Next, anti-lipidemic or dyslipidemic drugs. They can be continued. Atorvastatin and all. They can be safely given before surgery. They have no problem. And what are the drugs that we need to stop before surgery, guys? For that, I told you a hot MLC women. In that hot, H stands for heparin as well as herbal medications. Herbal medications. Heparin 6 hours before surgery you need to stop. Herbal medication 6 weeks before surgery you need to stop. O stands for oral hypoglycemic drugs need to be stopped before surgery. Okay? Oral hypoglycemic drug. Why? Because the patient is in a fasting state, that you need to be stopping oral hypoglycemic drug on the day of surgery. Okay. Next, OC pills need to be stopped 3 to 4 weeks before surgery, especially if it is a estrogen containing pill. T stands for TCA. HOT. T stands for TCA. TCA is tricyclic antidepressant. It has to be stopped 3 weeks before surgery. Okay. One more T. From that T, you need to remember one more thing. That is T stands for ticlopidine. It has to be stopped 14 days before surgery. Next, HOT, hot is done. M stands for monoamine oxidase inhibitor. again 3 to 4 weeks before surgery, you need to stop this monoamine oxidase inhibitor. Why? Because sometimes monoamine oxidase inhibitor reacts with pethidine and can cause severe sympathetic reaction. Okay. Then L stands for lithium. Lithium needs to be stopped 24 to 48 hours prior surgery as it prolongs the effect of muscle relaxant. Next is what, guys? ML is done. Next is C. C stands for most important drug. Clopidogrel has to be stopped 8 days before surgery. Clopidogrel. CLOPDRO. G is there, no? Always remember, I used to write this G as 8. So I need to remember, clopidogrel needs to be stopped 8 days before surgery. 8 days before surgery. Right. Okay. Last is W. W stands for warfarin. Warfarin, it has to be stopped 3 to 5 days prior surgery. Okay. So that's the mnemonic to remember. What are the drugs that can be given? What are the drugs that can be stopped? Okay. Next, guys. Now in this, what you need to focus most importantly, aspirin you need to focus, heparin you need to focus, TCA you need to focus, monoamine oxidase, lithium, and last, clopidogrel. These are the important drugs. Okay. Now guys, after doing the PAC, you give a certificate to a patient. What is that certificate called as? ASA. What is ASA? American Society of Anesthesiologists Certification. What does it mean, guys? ASA is basically a certification given to a patient that you are fit to undergo anesthesia. The risk of you undergoing anesthesia and coming back from anesthesia is nearly less or it is very high. That is basically given on the ASA classification. Right? Now, in the ASA classification, we are having 6 classes. Remember guys, ASA totally depends upon the systemic illness the patient is suffering with. Systemic illness the patient suffers with. In ASA, the class 1 is what? When do you call a patient as ASA class 1? When a patient is free from systemic illness. A patient comes to your clinic for a PAC. Systemic illness meaning what? Diabetes, hypertension, renal disease, heart disease, systemic illness. Patient comes to your clinic and he is posted for some surgery. He is not having any comorbidities. He is class 1. Class 2 means what? Patient having systemic illness which is well under control. Meaning what? Patient is having diabetes but his fasting blood sugar level is 90 and post-lunch blood sugar level is 120 and it is pretty much in the normal range. That is ASA class 2. Then ASA class 3. ASA class 3 means what? Patient having systemic illness which is not under control. यानी कि patient is having diabetes with his fasting blood sugar level of 200 and post-lunch blood sugar level of 380 यानी कि uncontrolled diabetes. That is ASA class 3. ASA class 4. ASA class 4 meaning what? Patient having systemic illness. Which is a constant threat to his life, which is a constant threat to his life. Now, what does it mean, guys? Constant threat to his life meaning what? Patient having a history of coronary artery disease or patient having a history of recent stroke, that patient comes under class 4. यानी कि systemic illness which is having a threat to his life during surgery. ठीक है? Class 5 meaning what? A moribund patient. Moribund patient. यानी कि with multiple comorbidities. Without surgery, the chances of survival are less. That is ASA class 5. Okay? Moribund patient. Example, ruptured abdominal aortic aneurysm. Ruptured abdominal aortic aneurysm. Without surgery, the chances are very, very less, guys. Okay? So, that patient comes under ASA 5. When do you call ASA 6? ASA 6 is a brain dead patient. Brain dead patient. Okay? To this ASA class, you can add a suffix E. Some alphabet of E can be added depending upon the emergency. If it is an emergency surgery, you add the letter E. Example, if the patient is posted for, I'll give you just one example, guys. A young lady posted for ruptured ectopic pregnancy management. She is having no comorbidities. Which ASA classification she belongs to? Patient is having no comorbidities means she is class 1. ASA is given on the systemic illness. Ruptured ectopic is not a systemic illness. But ruptured ectopic is an emergency. So she belongs to 1E. Alphabet E is added depending upon the emergency. That was regarding the pre-anesthetic checkup.